from the last lecture, we have distal radius and ulna here. The distal radius will have a styloid process. The distal ulna will have a styloid process. The radius will have two little articulations with a couple of bones that we like a lot, which is the scaphoid, or the scaphoid if you like, and the lunate. A couple of carpal bones. So we discussed this just briefly last time. And then the ulna will articulate with the radius here at the distal radioulnar joint. All right, so this is actually kind of a cool picture here where they've got the wrist basically snapped off where the radius and the ulna would be. So look like you're looking down the barrel of the radius where you can see the two facets here for the scaphoid and the lunate. And then you would get a little bit of a pocket of cartilage that would fit into this space where the laser is right now. It's called the triangular fibrocartilage complex. It's basically no yield for our purposes now, but we'll talk about it next when we do the clinical imaging, and it can be relevant for some things. So distal to our distal forearm, we'll see our carpal bones. There are 8 carpal bones, which we'll actually deal with a lot. They're very clinically relevant. Distal with that, we'll see some metacarpals, and they're named just like the digits are named, or I should say numbered like the digits are numbered, 1 through 5. So you have metacarpal 1, 2, 3, 4, 5, just like that. And then phalanges. So the phalanges, we have proximal, middle or intermediate, and distal phalanges. The thumb only has 2 phalanges. It's a little shorter, so it's missing one joint. So you just have a proximal and a distal phalanx in the thumb with just one interphalangeal joint. Remember, in your fingers, you have a proximal interphalangeal joint and a distal interphalangeal joint, so we got a little bit more range of motion there. All right. You also, this is not ones we would try to label, but something you might up in an X-ray. Every last one of us in here has a couple of what we call sesamoid bones, maybe a new term. Sesamoid bones are bones that form inside of tendons. So everyone's got them in the thumb. No one escapes these. But there's lots of places in the body where they might have some. Some people might have them, and other people might not have them. And so if you see a hand or a wrist radiograph, you normally catch a couple of these sesamoid bones, which are literally just living inside of a tendon of some muscles. All right, that's a good, strong start. Let's zoom in on the carpal bones and talk about this. So we've done some X-rays. We've done a little bit of X-raying so far. We looked at the shoulder, looked at the elbow. And today we're going to look at the carpals. So you can do wrist X-rays or you can do hand X-rays. And there's different, each series has its own, views that you would collect. So in a wrist X-ray, you're going to get usually a PA X-ray. So you can see the X-rays would hit posterior first, actually, normally. And will illuminate, hopefully, all of our little bones here so we can evaluate them. If we've had a patient come in, they have some sort of trauma or something like this, having pain in and around the wrist. There's lots of indications for why one may order this kind of X-ray. So we can see the radius here. Here's the styloid on the radius. Over here we see the ulna and the styloid on the ulna. This cartilage, it's kind of a triangle shape. That's why they call it the triangular fibrocartilage complex right there. And then distal to that, we see our carpal bones. So we'll start, I like to think there's 8 of them, so I think of them as 2 rows of 4. The first 2, I start with the first 2. I like to start with these because it helps me remember that they articulate with the radius. So the 2 that articulate with the radius directly are the scaphoid and the lunate bone. Scaphoid, lunate. Scaphoid is Greek, it means boat. So it's kind of like a little boat shape like this. Scaphoid, lunate. And notice I'm working medially toward the pinky. Medial side, pinky side. This is the thumb, so this would be lateral, right? The radius is also lateral, and the ulna is medial, so that would be another clue. So I see scaphoid, lunate, and over here I see 2 bones. I see the triquetrum here, and then I can see be sitting anterior to the triquetrum, immediately anterior to it is this hyperdense signal here, is the pisiform. Pisiform means pea shape, so it's kind of shaped like a pea. Everyone knows what a pea is. Your parents make you eat these growing up. I'm sorry. So pisiform. So that's the first row. Scaphoid, lunate, triquetrum, pisiform. I jump up to the next row now. I can see one here with usually kind of a bright circle, almost oval in it. This is the hook feature on this bone called the hamate. So if you look at the hamate here, you can see it has a little hook hanging off like that. I go lateral to that. I see the big captain in the middle. This is the capitate and the trapezoid. And finally, resting over here on the thumb, I see the so this trapezium thumb. All right, and a little memory device for this one that I like to use is down here. So long the pinky, here comes the thumb. So starting where we started, scaphoid, lunate, triquetrum, pisiform, so long the pinky, I jump up to the hamate, here comes the thumb. This can kind of, in your mind, organize them, make sure you account for all of them, and I would be able to ID these on a wrist x-ray, just make sure you can pick these out. Yeah, that's a good start, so kind of just outlining them there. And you get a lot of this. This is a great example. When I think of superimposition in x-rays, my first thought is probably to these two bones. So remember, x-rays are all compressed onto one two-dimensional image. So as a clinician or a practitioner of anatomy of some kind, you should know that the pisiform bone and the triquetrum are just superimposed. And the right signal there. All right. A couple of clinical correlations with this, and these are important clinical correlations. One is a distal radius fracture. So distal radius fracture, they come in different flavors, and probably the most famous one is a Colles fracture. Anyone familiar with this? You ever heard of a Colles fracture? Anyone have had a Colles fracture? They're very, very, very common. So any kind of fall on outstretched hand can elicit, can challenge the radius here distally, and it likes to snap off right there. Okay, so Colles fracture is a distal radius fracture and dorsal angulation of the distal radius fragment, giving the individual what they call a dinner fork deformity, like this. So it kind of, the arm kind of comes up and makes a little hump like this, kind of like the shape of the outside of a fork. Another important clinical correlation is a scaphoid or a scaphoid fracture. So scaphoid fractures are super duper common. It's so common that if you're a clinician, you ordered a wrist x-ray, that is the first thing that you're worried about is a scaphoid fracture. Of course, you can fracture other little bones in there, but man, this guy likes to break. It likes to break. It's kind of shaped like a peanut. It's got like a fat front end, an anterior pole, and a bit of a fatter back end, and a little narrow waist, so it's kind of shaped like a peanut shape. And at that waist, it really likes to fracture. So if you fall on outstretched hand like you see here, your radius here, remember, is articulated, guys, the lunate and the scaphoid. So they're going to get it. They're going to get a lot of that force, and you can fracture the scaphoid, very common. Now, that in and of itself necessarily isn't so bad, because they can go in, they can put some pins in it or whatever. What can happen is a very common outcome of scaphoid fractures is the development of aseptic necrosis or avascular necrosis. And this is because the scaphoid's blood supply is super tenuous here. So what happens is the radial artery is coming into the hand, it gives off a blood vessel that will go onto the scaphoid, and you can see it actually recurs. It actually kind of has to loop around backwards like this. So oftentimes, since the artery is coming through and it's giving off its branch and it recurs backwards like this, oftentimes this more proximal element of the scaphoid will lose its blood supply, and it's so bad that it just becomes sclerotic and necrotic, literally. So they have to deal with this. They have to deal with this. You'll get really bad arthritis and stuff that sets in. So avascular of the scaphoid. All right, so just to review, we talked about this some yesterday, because you kind of have to talk about how your fingers and your wrists move in order to understand forearm muscles and what they're doing. But just as a reminder, so with the wrist, we have flexion, extension. So I'm in flexion now, I go into extension here, flexion, extension. For your fingers, we practiced this yesterday, right? Fingers, just flexion, extension. They can also abduct and adduct. So remember, abduction up here at the shoulder, abducting away, adducting is adding it back. So you can do the same thing at your hand. But in the hand, the midline that we use to establish the midline for abduction and adduction is the middle finger. So the middle finger is the midline. So if you're moving away from the middle finger, you're abducting, and if you're a finger moving back toward the middle finger, then you're adducting. Not too bad. Okay. And we discussed this yesterday, so it's just kind of reinforcing this point. So you know, all these things combined, including the thumb actions, can give us some pretty cool and different recognized grips. So precision grip's an important one, power grip's an important one, but you know, we're creative. We use all kinds of different grips. All right, so let's start taking the skin off the hand. So we'll just start skinning the hand and work our way down. So we make an incision across the hand here. I see that the palmar aspect of the hand may have a little bit more superficial fascia. Recall yesterday we discussed the dorsum of the hand doesn't really have very much superficial fascia. You would just go, I mean, you just barely peel the skin off. There's really very little thickness of a fatty layer. You go straight into the bones and the tendons and stuff. So if you were to skin the palm of the hand, and like I said yesterday, the palm of the hand is a lot. It's a lot. That's why we have a whole lecture for it. So we just crack it open here, just slowly, and look on the underside. We see this sort of, I guess, triangle-shaped fascia called the palmar aponeurosis. So the palmar aponeurosis is this triangle shape. It's immediately under your skin on your palm. And it's covering up a lot of the goods there. Okay, it's covering up a lot of the vessels and stuff. You can see them poking out, hiding there underneath like that. On either side of the palmar aponeurosis, you'll see some muscular prominences. So if you're over here on the thumb side, you would see a big wad of muscles called the thenar eminence. Remember, thenars for your thumb. And then over here on the pinky side, you would actually see a hypothenar eminence. The hypothenar eminence dedicated to the pinky, and the thenar eminence dedicated to the thumb. Before you saw that, you might also see a little tiny guy, no yield really, but just for completion's sake, a little tiny muscle called palmaris brevis. We'll talk more about palmaris brevis, and I just like doing this. So we'll talk more about palmaris brevis. Here we'll talk about this muscle in your neck. Guess did you ever do this? Like, are you kind of like, you know this muscle?
Yeah.
You use it, right? It's called the platysma muscle. You use it to like pull your skin tight. It's actually inside of your skin. It's like inside of the superficial fascia of your skin. It's not under a deep fascia like your biceps is. Well, palmaris brevis is kind of the same way, honestly. So those muscles, the platysma muscle, palmaris brevis, and some others, they're remnants of what's called the panniculus carnosus. So if you're familiar with, like, if you've been around cows or horses or anything, or if you've been here long enough and you just drive down the highway and see some horses out in the field or whatever, and you see them twitching their skin, if you watch them long enough, they're doing that to kind of shoo the flies away. It's because they're covered in a muscle just like this. They have like a platysma over their whole body. No yield. Okay, I've gone too far. That's just a fun story. All right, so moving on then, so let's dive into these eminences. So remember, for the thumb we have the thenar eminence, or the thenar compartment. And there are three muscles in the thenar compartment that are just dedicated, just thumb movement only here. We'll have a muscle for flexion. This is flexor pollicis brevis. Remember, pollicis is a thumb term here referring to the thumb. So we saw flexor pollicis longus in the anterior forearm. So here's the brevis. You'll see an abductor. So this is abductor pollicis brevis. So these two. So flexor pollicis brevis, abductor pollicis brevis. And in lab, what I would do is I would cut this tendon of the abductor pollicis brevis like this, and I would flip it back, kind of like they've done here. And underneath you can see the opponens pollicis. And opponens, as you could deduce, is helping you with opposition of the thumb. So opposition is, remember, that combination movement with your thumb where you swing your metacarpal around and you can abduct and flex at the same time. So it's a big combination movement, so the pad of your thumb is facing your palm. So this is opposition. So we have a dedicated muscle for that as well. All right, so these three muscles of the thenar eminence are innervated by the recurrent median nerve. We like this one. The recurrent median nerve is a super duper important nerve, and it's a branch of the median nerve. In fact, I can see a lot of these little nerves entering the palm of the hand here. Most of them, except for this one over here. They're just derived from the median nerve, so more on that later. And a very important branch here in our eminence is that recurrent branch. Again, recurrent because it's coming back from where it came. So the median nerve would be passing through the carpal tunnel, spraying off these sensory branches, and then it'll throw a branch that goes backwards into the thenar compartment. It's often referred to as the $1 million nerve. $1 million nerve going to the thumb. It's called the $1 million nerve because if you're a hand surgeon and you accidentally cut your patient's recurrent median nerve, you're going to be paying them $1 million because they're going to be disabled. Like losing access to most of your thumb movements would be a life. It would be for anybody doing anything. You would just not be the same anymore. So it's not a huge nerve. I would say it's about as big around as this cable right here. Actually, the recurrent branch of the median nerve. It's not that big. All right. So another little sidebar on here. We're just emphasizing the thumb. Look at this Any guesses about what this guy may be?
Orangutan.
Yep. I was hoping you wouldn't say Dr. Mahaney or something like that. Don't tell him I said that. But you're right, yeah, that is an orangutan. Chimpanzee over here. We can see that their thumbs are, yeah, I mean, this one maybe a little more prominent. But yeah, they're tiny. They got these tiny thenar eminences like that. And I'm not trying. I just want you to have a look at my thumb. Now that is a thumb, buddy. That is a thumb. If you look at your thumb, you can see this big mass, this dedicated giant muscle mass that we have down here for moving our thumb around. So it's super important, you know. And that thenar eminence is actually what's making up all that bulk right there. And the reason I kind of talk about the apes here for a second is for a clinical reason, actually, because damage to the median nerve, if you lesion the median nerve, or if you specifically lesion the recurrent branch of the median nerve, then you would lose those muscles. And after muscles go for a while and they're not getting a neural signal, then they'll atrophy. So they undergo a disuse atrophy like this, and they'll just die. They'll start to die off and shrink like this. So that happens, and they call this injury a ape hand because it makes your hand kind of look like a flat, thenar eminence like we saw on the orangutan there just a minute ago. Yeah.
Since the chimpanzees and the apes are the chimpanzees and the orangutans, their thumb is like smaller. Can they still have the same movements we can?
That's actually a good question. I don't know if every one of these species all have the same musculature as we do. They do not have the same range of motion, and they're very, very poor opposers of their thumb. So I don't know if they have a muscle that's called opponent's pulse. Maybe they do. I don't know.
Because it's smaller, they can't do that.
Smaller, weaker. So they're very hook grip like oriented. They'll just hook like this. Their thumbs are kind of just along the rod. Give it the ability to oppose, make like a precision grip. Yeah, that's something we would be a lot better at. Yep.
I have a question, and this is just kind of my own curiosity. My thumbs are not super, they only go this far because of trauma to my hands from volleyball.
Oh,
And so I was just curious, when we talk about opposing, it's talking about this, but like how, like if there's constant trauma on it, is that more like a muscular issue or like a bone?
It's hard to say. I mean, if your thenar eminences look okay, like if they're still pretty bulky, yeah.
They used to be bigger though.
Yeah, I mean, I don't know, maybe it is a mix then. It would be surprised if you had nerve damage from that. So maybe it is joint related or some sort of stiffness or something like that that's limiting your range of motion in your joints. I don't know, that's just my guess, I guess. From 10 feet away, that's my guess. I don't know though, it's a good question. Could be a little bit both, who knows? Okay, so with the ape hand, so just remember median nerve injury, or so of course if you lesion the median nerve way up here in your elbow, this person will develop an ape hand, right? Because that recurrent branch, which is downstream of that, will be affected. But it could just be an iatrogenic. You're in the OR and you or whatever, and you develop this. Now, it's not as common anymore, and particularly in places where people have great access to healthcare, because if they have persistent carpal tunnel, and it's in areas where the healthcare is abundant and easy to access, they're likely to go get that treated, right? That median nerve lesion in the carpal tunnel treated, and they wouldn't develop this. But I mean, definitely people could develop this if you just went on with chronic carpal tunnel syndrome and median nerve compression. It would end up being the same kind of injury. So that's the big takeaway. So atrophy, the thenar eminence, and the thumb will also kind of fall out of line. So it loses its tone. It may fall kind of back like this, so it's more in line like an ape hand. Yeah. So long story short, if you get into any kind of I guess physical competitions with orangutans or chimpanzees, it would need to either be a long distance running. We're better long distance runners. That's kind of our jam. Or a thumb war. That would be those are the only two physical competitions you can beat a chimpanzee in. All right. Pretty good. All right, so let's move on to hypothenar eminence. So the hypothenar eminence is dedicated for the pinky. And if you notice carefully, the name scheme for these three muscles of the hypothenar eminence are actually mirroring the name scheme for the three muscles in the thenar eminence. So remember, in the thenar eminence, we had a flexor for the thumb, flexor pollicis. We have an abductor, and we have a muscle of opposition. We actually have the same thing over here for the pinky. You have an abductor digiti minimi for the little digit. You have a flexor digiti minimi brevis, although there is no longus, and a muscle of opposition, an opponens digiti minimi. All right. Abductor, flexor, opponens, and this is dedicated to the little digit. So you can't oppose your little digit as well, not quite as well, but you're able to swing the metacarpal for the fifth digit around like this to kind of oppose the thumb. So they call this opposition. Now, unlike the median nerve, the recurrent branch of the median nerve innervating that thenar, the ulnar nerve is actually getting in on some of these. So the ulnar nerve, specifically the deep branch of the ulnar nerve, will innervate this trio in the hypothenar compartment. Anyone know who this is? I might like. Okay, yeah, you know, like all my social references are slowly dying out. I have to replace them with more and more relevant things. All right. All right, so we've done it. So we've gone through the thenar eminence, we went through the hypothenar eminence. Let's look at some deeper muscles in the palm. So you can see a lot of the musculature and even some of the arteries and everything have been dissected away. And I can see the median nerve is revealed inside of the carpal tunnel, this little tunnel here. And I can see they've illustrated in its recurrent branch. Remember, that's associated with eminence. Remember, the hypothenar eminence over here is associated with the deep branch of the ulnar. So let's trace the ulnar up. Here's ulnar, ulnar, ulnar. It's traveling with its artery. It goes up like this. And you would see the ulnar have a deep branch which goes down and kind of curves. You can see it hooking into the deep hand. And along the way, the ulnar nerve, the deep branch of the ulnar nerve would innervate these hypothenar muscles. You'll also innervate a muscle that's all the way over here on the thumb side of things. Now, this is a thumb muscle, but it's not a thenar muscle, so there's a bit of a distinction. This is a muscle that's involved in adducting the thumb, so this is adductor pollicis, and it is innervated by the deep branch of the ulnar nerve. So don't get confused, even though it is a pollicis and it is over here on the thumb side, it actually doesn't get that recurrent median nerve, it just gets the deep branch of the ulnar nerve. So if you're in an abducted position, kind of like this, you would use adductor pollicis just to bring the thumb back to a neutral position. All right. Other things you'll see in the palm, you'll see what are called interossei muscles. And this is a good name for it. So inter means between, osseous referring to the bones. So these are literally between the bones in your palm. So the interossei muscles, there are 3 palmar interossei, and by the deep branch of the ulnar nerve as well. So what are these interossei muscles up to? I think it's easiest to think about them all at one time. So for the 2 sets of interossei muscles, you have a set on the front, there's 3 on your palm, so palmar interossei. Then you have 4 actually on the back side, dorsal interossei. So what do they do? So the memory device for remembering their function is dab and pad. Dab and pad. So dorsal interossei AB duct and palmar interossei AD duct. So if we go back, I could figure, so here's our thumb. It kind of makes sense that on your second finger here, if you're going to AD duct this back toward the middle finger, adding, remember the middle finger is the midline here in the hand, that this palmar interossei would pull this proximal face toward the middle finger. Okay, similarly for these. For 4 and 5, so pulling it toward the middle finger. So there, if you're in an abducted position with your fingers like this, and you're going to add these digits back toward the midline, you would use those palmar interossei. And on the other side, on the flip side of things, these are on the back of your hand, and you can palpate these. These are easy to feel. These are really the only muscles that you have on the back of your hand, but you can feel like a big wad right there. That's the first dorsal interosseous muscle. You can feel any kind of soft tissue in between your bones. Those are all dorsal interossei. So the dorsal interossei are doing just the opposite. You have one dedicated for the second digit here, which will pull the index finger away from the middle finger into abduction. The middle finger actually is 2 dorsal interossei, and the reason is it's abducting. The middle finger is by definition the midline, I guess you could say. So it's only ever abducting. It's only ever moving away from the midline. So you have 2, one on either side of those that would here from side to side. And then finally a 4th one way over here for your 4th digit. Okay, so that would be the abductor for your 4th digit. And then you have an abductor for your little digit, abductor digiti minimi, but remember the abductor digiti minimi is a component of the hypothenar compartment, which hangs off the side of your hand. So you can test the ulnar nerve this way. So this is actually not an uncommon clinical test. You can sort of isolate the function of the ulnar nerve, knowing that the ulnar nerve innervates the dorsal and palmar interossei, by asking them to like grip like this, grip a piece of paper, or even spread their fingers against your resistance. So if you were to kind of put your fingers like this and give them a little bit of resistance, say, okay, spread your fingers as wide as you can, and you're testing, and also at the same time testing the nerve which innervates them. All right, almost there. There's lots of muscles in the hand, lots of muscles. But these are cool. These are interesting muscles, and they have a cool clinical correlation here. The lumbrical muscles. So lumbricalis is Latin that means worm. Worm. So whenever you dissect a hand, the lumbrical muscles, they genuinely look like little earthworms in between your tendons. You have 4 lumbrical muscles, and what's interesting about the lumbrical muscles is their origin, okay, where they're pulling from, is actually the tendon of the flexor digitorum profundus. So remember that from the last lecture, flexor digitorum profundus, flexing these digits down. So these 4 muscles will actually arise from the tendon of flexor digitorum profundus and wrap up your fingers just a little ways, you see here, and they'll insert onto that extensor expansion on the back of your finger. So kind of an interesting little muscle. Something to note about them, some of them are unipinnate, meaning they're just like a one-feather muscle. Some of them are bipinnate, looking kind of like a two-feathered muscle, if you will. And a very, very important point, the most important point probably, is that they receive different innervations. So the first and second lumbrical muscle are innervated by the median nerve. Lumbricals 3 and 4 are innervated by the ulnar nerve. So what do the lumbrical muscles do so they're pulling from the flexor digitorum profundus tendon, they're wrapping around and inserting onto this extensor expansion. Remember what we talked about yesterday, the extensor expansion actually works by splitting into different slips. So you have this central slip that will go over the top of your proximal interphalangeal joint, and then you have these little collateral slips that go over the top of your distal interphalangeal joint. But you can see that the lumbricals tendon is actually crossing the MCP joint, or the metacarpophalangeal joint, in the front. So if you think about the physics of this, if you will, whenever the lumbrical muscle is pulling, it actually flexes your MCP joint because it's crossing on the anterior ventral surface of it. But since the extensor expansion, via its 2 slips here, crawls over the backside of the interphalangeal joints, it will actually extend your interphalangeal joints. It's weird to think about. So it's one muscle having opposite actions on different joints. This is a good picture to kind of understand what the lumbricals are up to right here. So if you're doing just this, where you're flexing at the MCP joints, but your IP joints are extended like this, not flexed, but extended, then you're simulating the action of the lumbrical muscles. Okay, and we remember dual innervation here. Lumbrical 1 and 2, median. Lumbrical 3 and 4 is ulnar. Whew, that's a lot. So big muscles that we have in the palm of our hand. A couple of things I'll point out is the ulnar nerve, man. Wow, just coming in clutch here. So all this is ulnar. 2 of our lumbrical muscles are ulnar, like this. So when I think about intrinsic hand function, intrinsic meaning the muscle begins and ends in your hand. It's not coming from your forearm and going into the hand. When I think about intrinsic hand muscles, my first thought is ulnar nerve. I mean, the ulnar nerve is the heavy hitter here. What I do is I just try to remember the outliers. So the outliers here are the first 2 lumbricals, they're the median, right? And then the thenar muscles. So the thenar muscles are also median. There's some nice patterns to be picked up on there. All right, we did it. So we talked about the muscles. Let's move on to the arteries. So the arteries in your hand, we have 2 arteries in the forearm that you remember from the last lecture. Ulnar artery on the medial side, radial artery on the lateral side. For the hand, they actually will form 2 loops or arches, 2 arterial arches. So the ulnar artery will come up like this, and if you were to carefully dissect away that palmar aponeurosis, that little triangle fascia that we saw up front, if you carefully dissected that away, then you would reveal the superficial palmar arterial arch. That's what we see here. So the superficial palmar arterial arch, you can see, is got some contribution from ulnar, but you actually have the radial artery giving some contribution like this. And in most people, unless you have an incomplete arch, will have a complete little arch of blood supply here. Now coming off the arch, you have what's called common palmar digital arteries. So common palmar digital arteries, the name common should sort of trigger your thinking. It's about to split into something. The common palmar arteries will split onto adjacent fingers as proper palmar digital arteries. So a tag up here on the finger bone, this is a proper palmar digital. And I know the adjacent fingers proper palmar digital. They both came from a common palmar digital down here. Okay, so that's the arrangement for how this works, getting the blood all the way out to the tips of your digits. This is a dissection where you can see the thenar eminence here laterally, hypothenar eminence here, and I can see some of the tendons, maybe some of the flexor digitorum tendons in there. And they've injected the arterial system with latex, so you can see this bright red. Your arteries don't really look like that. Unfortunately, it'd be nice if they did, because it'd be easier to tell them from veins. But they injected it with a red latex to exaggerate that superficial palmar arterial arch. So you can see coming away from those, like this one, for example, would be a common palmar digital. And I can just barely see, actually, you're right, here's a good one. I can see the split into adjacent proper palmar digitals right here. Little tiny nerves, some median nerve branches there. All right, so why is this important? So one reason it could be important is Allen's test. Anyone heard of Allen's test? Been in and around the clinic or scribed or something, you may have heard of this. So Allen's test is a test of your collateral blood flow and its integrity. So I don't know if the sound is on here. We'll see. The sound is not on, so I'll narrate here. Oh, wait. He's talking. Let's go back. Sorry, people on the other side of the wall. It's coming. Source volume, maybe? Let's try this. So he's going to explain what this is. And what this is you testing the integrity of the arch on the inside of your hand from both the ulnar and the radial perspective. So if you compress the radial and the ulnar artery at the same time, your hand will just blanch, right? It's not getting any blood supply. But if you wanted to test, for example, to see if the ulnar artery has good blood flow and it's patent, it doesn't have a big blockage, or you make sure your arch is complete, you can leave your finger on the radial and just take it off the ulnar, and the whole hand should blanch. The whole hand should fill, right? Because there's an arch. There's like a giant anastomosis between the two.
The hand is exsanguinated, and the ulnar and radial arteries are compressed. And then released, and you can see that there's not much blood flow because the hand is pale. You release the ulnar artery, and you can see that the hand picks up nicely, indicating sufficiency of the ulnar artery system.
Cool, and this is a pretty common thing they'll do before anesthesia. We'll do this beforehand. If you have a heart procedure, even we'll do this beforehand. Because if they want to access your radial artery, which is not uncommon if you have a heart procedure or something like that, they're going through your vessels, and if they want to play around with this radial artery, they can't off your radial artery for clinical purposes if your ulnar artery is not going to help perfuse your hand, right? The ulnar artery's got to be there to back it up. So reasons why it may not back it up, one is like a thrombus. So if you had a thrombus or something in there that's blocking the artery, of course that would compromise your blood flow to your hand. Another reason why you may have compromised blood flow in that case is if you had an incomplete arch. I see this a lot in the lab, like in the anatomy lab. If the arch doesn't come fully together and connect, then they're technically separate entities. You have a radial artery perfusion and an ulnar artery perfusion. So you can see in this individual, they have an incomplete arch. So you can see they're compressing the ulnar artery, and it's only, but the radial artery is still filling, but only part of the hand, right? And then just the opposite. Does that make sense? So they do this a lot, actually. Allen's test is quite common. Okay, digging more, carpal tunnel. So carpal tunnel is a high yield area in the wrist and hand. We have to be familiar with this. We alluded to it a little bit yesterday, talking about the tendons of some of these muscles. So What is the carpal tunnel? So the carpal tunnel is a tight little space that's basically bound by your carpal bones. So all you remember your carpal bones that we just went over. So along the pinky here comes the thumb. They are, and they kind of curl like this. I say kind of. They actually curl a lot. So whenever you're in the lab, you can stick if you get the tendons out, you can feel your carpal tunnel is a deep pocket, buddy. I mean, it is a deep, deep pocket. Still, unfortunately, not enough space to go around in there. And the carpal tunnel is covered on top by the flexor retinaculum. So this flexor retinaculum would sort of act as the roof over the carpal tunnel. So what's going through the carpal tunnel? So what's going through the carpal tunnel is 9 tendons and 1 nerve. 9 tendons and 1 nerve, and I can see them packed right in there. Okay, shouldn't be any arteries. So you have the 4 tendons of flexor superficialis, so flexor digitorum superficialis, the 4 tendons of flexor digitorum profundus, and flexor pollicis longus, if you remember that one, flexing the thumb. So these 9 tendons collectively pass through the carpal tunnel, and they do so along with the median nerve. So that's actually how the median nerve enters the hand. It does so under the flexor retinaculum and through the carpal tunnel, just like this. The ulnar nerve, on the other hand, does not. It actually passes over the top of the flexor retinaculum. So if you had a carpal tunnel syndrome, any problem in there where you don't have enough space to breathe in there, the ulnar nerve would be fine. It would be unaffected. So of course, the syndrome here is carpal tunnel syndrome. So with carpal tunnel syndrome, you can see this cross section has been cut right across the carpal bones and the flexor retinaculums. Here's the flexor retinaculum. Here's our 9 tendons like this, and you would have the median nerve tucked in there with it. So a little more anatomically accurate would be something like this. So there's the carpal tunnel. There's a little extension here of tissue that goes over the top. It's not part of carpal tunnel here. It's a different tunnel that the ulnar nerve will enter. It will be over the top of the flexor retinaculum. They call it Guillon's tunnel. So Guillon's tunnel is how it enters the hand. And then there's a little side passage for flexor carpi radialis, actually. All right. So the carpal tunnel syndrome. So this is very, very common. So the patient history could be relevant. So this person, they may have some sort of job where they're using their fingers and digits a lot. Classic way to be written is there's some sort of there's typing a lot. So it could be anyone taking a lot of notes or something like this. Maybe you guys, you're taking a lot of notes. So try to lay off the note taking. Maybe that's the recommendations. But it's super common. It's one of the most common MSK complaints is carpal tunnel syndrome. So what happens if with this overuse in there, the synovial, usually what happens is the synovial lining on the inside, it gets irritated. So all of this kind of blue stuff, remember they're surrounded by the synovial lining, gets irritated and invites a lot of swelling and immune response in there, and you just don't have any room anymore. And the tendons, your tendons are still going to work. They produce a lot of force, but since there's no room in there anymore, your nerve does not like it. So your nerve can get squished. And if you had a median nerve lesion, right here, lesion I guess is a good word for this, then you're going to expect downstream median nerve symptoms, which, as you know, may affect the thenar eminence. So they may have some amount of thumb weakness. The most common complaint is a sensory loss or a sensory disturbance, I guess you would say. And remember, that would be over the median nerve distribution in the hand. So the cutaneous distribution of the median nerve in the hand, remember, is money. Remember, median is money. So it'd be over the anterior surface of your thumb, first and second digit on the front side, and then maybe down into the palm here, maybe a little bit. Palm's oftentimes spared in carpal tunnel syndrome for reasons. There's actually a little tiny nerve branch that jumps off of it. I'll draw it in. So before it goes into the tunnel, it actually gives off a little branch like this that goes into your palm skin. So sometimes your palm is spared. All right, so just consider that patient profile. They come in, you got their history, what they do for a living, you got their major complaint here, sensory loss, maybe some thumb problems. You can eliminate ulnar nerve, you can eliminate radial nerve, you're worried about the median nerve. So what about the ulnar nerve? So the ulnar nerve goes through Guillon's tunnel, or the ulnar tunnel here, and we talked about it giving off its deep branch earlier, and we know the deep branch of the ulnar nerve is the heavy hitter for intrinsic hand muscles. When you think intrinsic hand muscles, your next thought is deep branch of the ulnar nerve, and you just remember the exceptions to that rule, which are the median nerve. Also importantly is you'll have some cutaneous branches. So the cutaneous branches of the ulnar nerve, recall, will do the 5th digit and the medial half of the 4th digit, along with the medial palm as well. So this part of your hand here, this is the palmar surface of your hand, 5th digit, half your 4th digit, and the medial aspect of the palm, all done by. All right, so, I mean, you got carpal tunnel lesions, and you can get Guillain tunnel lesions as well. So these are a little less common, but they do pop up. I mean, they are pretty board relevant. They're in the BRS, and you'll see them out there. So it's a good one to be familiar with. So Guillin's tunnel here, you can have similar kinds of issues, maybe a thickening of the retinaculum or something like this that can cause a ulnar nerve entrapment inside of Guillin's tunnel. A very, very common way to see this in a clinical presentation is actually if you have been leaning the medial aspect on something for a long time. So we have a student now, a first-year student, that I think probably has this, from based on what he described to me. So sitting at his desk, he was like, I guess the way he was leaning on his desk, the medial part of his hand here was just compressing, and he just ulnar nerve symptoms. So you can also call this handlebar neuropathy. So cyclists sometimes will complain of this because they rest the medial aspect of their wrist against their handlebars, and that just compresses the ulnar nerve in the thumb. So what if you have proximal ulnar nerve lesion? So if you have a proximal ulnar nerve lesion or a lesion that's up higher, maybe a ulnar nerve lesion in the cubital tunnel or something like this, that can happen as well. That's another issue you could have. So if you have a neuropathy like this, you might or you might not get super bad symptoms. I mean, if you had like a full nerve lesion, of course, everything downstream of the nerve, motor and sensory, would be affected. But these are usually a little bit more transient. If you had a more violent ulnar nerve injury, maybe you had a medial epicondyle fracture, and the cubital tunnel was compromised, and the ulnar nerve was severed like this, and you lost all, then you would end up like this. So they call this the ulnar claw. The ulnar claw. And the ulnar claw kind of looks like the sign of benediction from yesterday. Kind of looks like the sign of benediction. But it's a little different in that it's not an active, so you wouldn't have to say, okay, patient, make a fist, and that would give you the sign of benediction. You're associating that with median nerve injury. The patient, upon receiving this, if they just fresh out of the car accident, their ulnar nerve is just lesion, they would just show up like this. They would show up, if you notice the difference here, there's a slight hyperextension of the MCP joint. So the MCP joint is hyperextended a little bit, whereas the sign of benediction, you asking them to flex down. So why does this happen? So the reason this happens is because the lumbrical muscles. Remember, I told you that was important. So the medial two lumbrical muscles, 3 and 4, which are dedicated to digits 4 and 5, are denervated because you lesion the ulnar nerve, right? And whenever this happens, the extensor digitorum muscle is pulling unopposed. It's pulling unopposed. So it has no other tonic kind of competitors. So if I were to ask you, just think with me here for a second. If I were to ask you to use your extensor digitorum muscle on the back of your forearm, the one that goes out to the back of your digits to extend them, if I were to ask you to show me what you think that does whenever it fires, show me what you think it would do. Anyone? Extend, so extensor digitorum. These are good guesses. Yes, this is totally reasonable. So extending the digits is where you might go with this, right? And that's not bad. That's a pretty good answer. What it actually does, if you were able to fire extensor digitorum all by itself, is you would make just a claw like this. You need lumbricals to do that. Yeah, you need lumbricals. It's an intrinsic hand function. So getting from here to here, you need lumbricals. All right, and this is the explanation for the clinical signs and symptoms that you see in ulnar clawing. So if you lose lumbricals 3 and 4 associated with the ring finger and the 5th digit, the instant your ulnar nerve gets cut, if you your digits like this, then there's nothing to keep them from clawing like that on 4 and 5. Does that make sense? So that's ulnar clawing. Any kind of ulnar nerve lesion could end up this way. This also explains, if you remember all the way back, Klumpke's claw. Remember the lower brachial plexopathy? So remember you had the Erb's palsy with C5, C6. So Klumpke's palsy was a full claw hand. Remember, so these babies, they come out and have this little claw. That's because C8 and T1 are the spinal levels that go into all the lumbricals. So in those babies, they lose all their lumbricals like this. Other signs and symptoms you may see in this patient, if they damage their ulnar nerve upstream and it's busted, what kind of sensory symptom would this person complain of? Good, yeah, you could also take the same person if you're suspicious of a big lesion here and say, oh, can you feel this? They wouldn't, right? If it was a full lesion, they could not feel that. And then the medial half of their fourth digit. You could also test some other intrinsic hand muscles. You'd probably be convinced at this point, but just in case, you could test the resist my fingers, so abduction against resistance. Remember the interossei muscle, also ulnar nerve. So lots of different potential pieces to put
So
together.
if they were like to hit their hand on the desk, like they wouldn't feel that at all? Like
What-
for the last digit?
Yeah, so if they, so they would have no cutaneous sensory information
So if
at
they
all.
hit it, they're not gonna
So
feel
any
it.
kind of pain, any temperature changes, so thermoreceptors would be gone, proprioceptive would be gone, you know, for all that, so, yeah. Right. Cool. Ulnar clawing. Any questions on ulnar claw? All right, we're getting there. The last few slides are summary slides to more or less help you prepare for some of these nerve injuries. So almost done with the hand. So we talked about the superficial palmar arch, one coming from the ulnar and one coming from the radial here to make our superficial palmar arch. Just for completion's sake, there is a deep palmar arch. So essentially, whenever the two coming together like this to make the superficial palmar arch, they really split twice. They really make kind of the two connections. One arch is superficial and the other arch is deep. So you can see in this image the deep palmar arterial arch. The deep palmar arterial arch is a little more proximal in the hand and it's deeper, as the name implies. And the way it's formed is actually from the radial artery, which enters the snuff box. So it's about to enter the snuff box right here, right? The anatomical snuff box passes behind so the dorsal surface of the thumb. And the radial artery will actually terminate by giving off a dedicated vessel for your thumb. It's called princeps pollicis, and one for the lateral side of your second digit. And you can see that part of it just continues on to make one continuous loop with the ulnar artery. So at the end of the day, ulnar and radial making two loop connections, a superficial palmar arterial arch and then a deep palmar arterial arch. Recall that the superficial palmar arterial arch will be the one that generates the proper palmar digitals and ultimately the common palmar digitals and ultimately the proper palmar digitals. So this is an angiogram here so you can see this. So here's our superficial arch and here's the deep arch. Yep.
So someone that has something like this, that arch isn't made?
It's incomplete, yeah. I actually see it a lot in lab. It's not terribly uncommon. So I guess that's why the Allen's test is so important because it's a very prevalent. It's not the majority morphology, but it is a very significant minority of people will have this. All right, so that's really it about. I'm going to take the last few slides to maybe prime you to start studying a little bit. I think the nerves are probably the hardest part of the exam. They are, I think, in MSK. Let's do a little bit of a quick recap on some of the nerves, where to look through them, where to pay attention. These are great summary slides for some of these. So starting with median, so we'll start with the median nerve. And we'll just address some of these points that they're passing through. So remember the median nerve is going to be coursing in the bicipital groove here. So it's going to be coursing in the bicipital groove, coming down, entering the cubital fossa. So it's going to be entering the cubital fossa. And just call an error. This should be the brachial artery. So it'll travel with the brachial artery in the little bicipital groove, so just behind the biceps muscle. It enters the cubital fossa, so remember the median is also a player in this TAN, T-A-N relationship, tendon, artery, nerve, so that's the nerve, biceps tendon, brachial artery, median nerve. It's innervating a lot of these muscles in the anterior forearm. So not all of, but almost all of our wrist flexors and a lot of our finger flexors are done by the median nerve. It would provide, so it would continue on, go through the carpal tunnel. So it goes through the carpal tunnel like this. Remember, it's going to innervate the thenar muscles. And you can even see Netter illustrated the first two lumbricals. So there they are. So done by the median nerve. And remember, median is money. Median is money. So this is the cutaneous sensory distribution of the median nerve. So ears are always up for cutaneous sensory findings. It's exclusive to the nerve, right? It can't be any other nerve that's doing this. And our important clinical correlations that we mentioned for the median nerves, the sign of benediction, the anterior interosseous syndrome. Remember trying to make the OK sign. Okay, remember this will be flat if you have an anterior interosseous nerve lesion. Carpal tunnel syndrome, of course, and then the APAN. The median nerve also does come out to these digits here and does your nail beds. So if you actually look at the median nerve distribution here, it kind of curls over and does your nail bed. All right, so that's median. What about ulnar? So ulnar, kind of like median, the ulnar nerve is just basically passing through your arm to get to your forearm. So the ulnar nerve is passing behind the elbow joint through the cubital tunnel, if you remember, coursing in the cubital tunnel between the medial epicondyle and the olecranon. It gets off a couple of muscles here, so remember the flexor digitorum profundus is dually innervated. Remember that dual innervation for a muscle is kind of rare, but the medial two digits done by the ulnar nerve here for flexor digitorum profundus and also flexor carpio-ulnaris for the ulnar nerve. The ulnar nerve continues on like this. It doesn't do any, just like the median nerve, it doesn't do any sensory innervation over the forearm, none. It's just passing into the hand here. Heavy hitter for intrinsic hand muscles, right? Huge. So the deep branch of the ulnar nerve is doing most of your intrinsic hand muscles, and along with the cutaneous distribution here. So it does the medial side of the hand, both the back and the front. Digit 5 on the back and the front, and about half a digit 4 on the back and the front. All right, so ulnar nerve. And a couple of ulnar nerve clinical correlates here. So this is a nice little summary. So we got ulnar nerve or cubital tunnel entrapment, some sort of cubital tunnel problem. Ulnar clawing, like we see here. Funny bone, of course, is kind of a fun one. Guillon's tunnel, so you got issue with Guillon's tunnel, and handlebar neuropathy. So patient, their history can be relevant oftentimes with your differential. So radial nerve distribution. Radial nerve is wrapping around the humerus. Remember, it's wrapping around the mid shaft of the humerus, not shown here. We associate that with the wrist drop injury. It's wrapping around the lateral epicondyle, kind of like a candy cane stripe. It splits into a superficial and a deep branch. The superficial branch of the radial nerve will go all the way to the hand here and provide cutaneous sensory innervation. So this is the territory of the radial, and there would be a little seam here where the ulnar nerve would take over. Recall the deep branch of the radial nerve will innervate a couple of muscles. Most of the muscles back here by the continuation of the deep branch of the radial nerve, which is the posterior interosseous nerve. So all of that would be kind of immaterial if you had a lesion, for example, like right here. If you had a lesion like way up here, or you had a mid-shaft humeral fracture or something like that, everything downstream of that's going to get it. All right, so that's radial. This is just a summary slide showing you the hand, so you can see the cutaneous sensory distribution over the forearm to the distal forearm, and then the hand. So palmar surface of the hand, remember median here in yellow, ulnar on the medial side, ulnar still on the medial side on the dorsum of the hand, and then radial on the lateral dorsum of the hand. Okay, just another summary. One way to think about the forearm needs more love, I think. But so this little, if you were to take a section through the forearm like this, you took a section just like that. This is essentially draw this little PowerPoint shape. So there's 3 cutaneous nerves for the forearm. You'll have this, if this is anterior and this is posterior, you have a lateral antebrachial cutaneous nerve and a medial antebrachial cutaneous nerve. So lateral will be here in green, that's a derivative of musculocutaneous, and medial from the medial cord. Then you have a posterior antebrachial cutaneous nerve, which comes from radial, and that would be on the back side. So if you slice all the way through the forearm, just like this, you have these 3 nerves covering that's just the skin territory, right? That's just the skin. The muscles on the inside, that's a different story. All right, so we'll play one game together really quick, and I'm keeping you a little bit. This is just follow me. Just let this wash over you here one time. So I talk a lot about these maps, right? These cutaneous nerve maps, and I say if you're good at this, then you know what you're doing, and that's true. If you are and you're dealing with peripheral nerve lesions, then you do know what you're doing. You're doing okay. But remember, I talked about dermatomes as well. Remember this zebra stripe kind of pattern. So how do you know when to use one or the other? When is the peripheral nerve chart relevant? When is the dermatome chart relevant? So let's do a thought experiment together here. So let's consider a nerve, the musculocutaneous nerve. musculocutaneous nerve, via the mixing of the brachial plexus, is derived from C5, C6, and C7. Remember, 3 musketeers assassinated? Yeah, so the 3 musketeers. So from C5, C6, and C7, they mix together via the brachial plexus. There's a lot to be said about that part, right? And they form the musculocutaneous nerve. But I said, what does the musculocutaneous nerve do? Go. You would say its motor branch would go to the biceps brachii, coracobrachialis, and the brachialis muscle. Biceps will do flexion of the elbow and supination. Brachialis would do a little bit of flexion at the elbow, maybe a little bit, it's not that much. And then the brachialis muscle would do flexion of the elbow exclusively. Okay, so that would be the muscle's job. And you should also know the musculocutaneous nerve has that lateral antebrachial nerve, that lateral antebrachial cutaneous nerve branch coming off of it there in green. So it does a little bit of cutaneous sensation as well. So if you put a lesion in the periphery, you lesion a peripheral nerve, this is what you would expect to see. Patient comes in, you've damaged biceps, coracobrachialis, and brachialis. Where their injury is at could be relevant, right? They just come in with this giant laceration or something, you're like, okay, well, it's in the periphery. If they come in and in this case, their elbow flexion is nearly busted, they would have basically no elbow flexion. Maybe a little bit of brachioradialis, but not really. I mean, so if you were to do both sides, you wouldn't have to do both sides. Just like one side is going to be absolutely busted, 0 elbow flexion. And you can test their forearm. You can say, all right, can you feel this on the medial side? Yeah, that's okay. What about this on the lateral side? Ooh, I can't feel that. Okay, what about your thumb? Yeah, I can feel that. That would be median nerve, right? Okay, so then you've isolated that and you've pinned that down on the musculocutaneous nerve. In this case, knowing the peripheral nerve cutaneous chart helps you. That's good. You want to know that. Now, let's just drive the lesion up higher. Let's say you have a C6 nerve root lesion. You may say, well, how do you get a C6 nerve root lesion? Where's the C6 nerve root? That is like in here. Like it's all the way up against your spinal cord, right? So how would you get this lesion, from what you know? So you have cervical fracture. The one we mentioned in lecture, the one that comes up a lot is the discs, right? So intervertebral disc herniation, that's usually the one. But yeah, I mean, if you had a spine fracture, even a tumor growing off your spinal cord or something like that, that could possibly affect it. So with this in mind then, if you lesion C6, think with me, if you lesion C6, could this person flex their elbow at all? Well, yeah, because C5 and C7 would be helping a little bit with that, right? So would it be weakened? Yeah, a little bit. It would be weak. Maybe you do both sides and you're like, okay, a little bit weak there. What the dead giveaway would be about their root lesion would actually be the dermatome chart. Yes. So if you say, oh, this is isolated at C6 and you are savvy with the dermatome chart, you say, oh, okay, patient, can you feel along here? Where's your sensory disturbance coming from? Where's the complaint at? Right along this distribution, man, all the way out. Remember Spokane? So C6 would be along the thumb. So this helps you localize this lesion from an MSK standpoint. So practice this. You got a little bit of time. I got to run. I got my next meeting, and we'll do lab on Tuesday. Elena will be helping us with lab, and we'll set up a review session as well. That way you're building up with confidence. All right, thanks for your time.
Okay.